Hello, my name is Alberto Arns, and the title of this presentation is Assessment Drives Learning: Principles of Good Assessment Tools. What is the relevance of this topic? In my opinion, an appropriate assessment program is the best learning tool in a residency program. Students study for the exams, not only the contents, but also the specific methodology of assessment. They prepare, in a different way, an oral exam than a written exam. The purpose of this presentation is to describe the principles of adult education required to build an effective assessment program to optimize the learning process. By the end of the presentation, participants should be able to describe 3 requirements of a postgraduate program, to explain the relation between assessment and the pyramid of Miller, to describe what a competency-based assessment is, to explain the importance of feedback in assessment, and to describe how to build a structured program of assessment. The contents of this presentation will be previous assumptions, that is, essential requisites of a residency program needed to build a structured assessment competency-based program. Number 2, to explain the cognitive Miller's pyramid, upon which most of the assessment tools are framed. Number 3, to understand what a competency-based assessment is. Number 4, to put on relevance how important feedback is to drive the learning progress. And number 5, how to build a structured program of assessment based on these concepts. Let's start with previous assumptions. A postgraduate program should be learner-centered. It must be adapted to students' strengths and weaknesses. Not all the residents start with the same knowledge level, nor learn to the same speed. Some have better psychomotor skills, for example, and others may be more skilled in patient interview otherwise. A holistic approach to learning rather than atomistic mastering oriented. That is to help in integration of knowledge rather than knowing everything that is known about a specific topic. And based on deep learning strategies. It basically means to put emphasis in practical rather than theoretical activities, based in real-life problem solving and to avoid just memorization of contents. Assessment is more than evaluation. Grades try to measure or quantify students' performance, what is appropriate for rank them or define a pass-fail judgment. When we talk about assessing, we refer to a continued longitudinal process that promotes insight and autonomous learning strategies. Assessment tools must be aligned with curriculum objectives. Assessment stakes are like traffic signals that guide the way of learning. If we want the resident learners to identify, for example, a narrow iridocorneal angle in real patients, the assessment tool wouldn't be just to describe the Van Herrick grades, rather to perform a gonioscopy and describe the iridocorneal angle in a real patient. The learning progress stands on successive cycles. It's like an uphill race, where every assessment stake is a cycle of training period followed by evaluation and feedback, repeated continuously from start to finish. Beware of situation case specificity. In this concept are also involved the concept of validity and reliability of a specific assessment tool, items that are going to be discussed in further presentations. We all know that teachers, students, and patients behave differently in different situations. This will have impact on behavior assessment, the generalizability of a single assessment take, and consider that practice under supervision would be very different than when the student is not observed. In summary of previous assumptions about residency programs, it must be learner-centered, there must be an holistic approach rather than a mastery-oriented, based on deep learning strategies. The assessment tools must be aligned with curriculum objectives, and the assessment stakes are cycles of training, evaluation, and feedback. Let's go to the second topic of this presentation, assessment according to cognitive Miller's pyramid. George Miller's cognitive pyramid is a constructivist framework assuming that complex actions are based on 4 levels of proficiency, where the basement or first level is a set of bricks of specific basic theoretical contents. The second level is built over the basement when the student is able to establish association or interrelations among those bricks. And the third level refers to ability to integrate them in psychomotor skills. Finally, the apex of the pyramid, or DAS level, refers to the ability to apply the acquired skills in solving real clinical problems. This model has been used to standardize the assessment tools according to what pyramid level need to be assessed. Progression of learning supposes also progression of assessment tools. Multiple choice examinations are often used to assess the first level, and the last level is more properly assessed with mini-clinical evaluation exercise, logs, 360 feedback, among others. We must keep in mind that the higher the level to be assessed, the evaluation instruments will be more subjective and less standardized. This issue guides us to the third topic of this presentation, that is the competency-based assessment. A classical definition of a professional competence given by Epstein is the habitual and judicious use of communication, knowledge, technical skills, clinical reasoning, emotions, values, and reflections in daily practice for the benefit of the individual and the community being served. When we reviewed the assessment tools to evaluate the DAS level on Miller's pyramid, we were assessing tridimensional clinical competences. But when we talk about professional competences, we are facing with a multidimensional issue, as defined, for example, in the Kahneman's role model or the ACGME framework. In those multidimensional models, we notice that professional competencies are domain-independent skills, or maybe an integration of all of them. And we say that professional competence is more than the sum of its parts, in the same way that shaking hands and establishing visual contact is not the same than establishing rapport. Any single assessment tool implies a compromise on quality criteria. Combining different assessment methods can alleviate the quality compromise. So, we must assume that when we assess competences, we must love the subjective and collective, integrating quantitative and qualitative information, using semi-standardized expert professional judgment, and collecting independent points of view rather than forging consensus among observers. Independent judges, which conform a 360 degrees view of the student's performance, including not only experts, but also his peers and himself. Now, let's go to the fourth topic of this presentation, the relevance of feedback. Feedback is essential in assessment. In residency program, mentor and teachers must also be evaluators and judges, and sometimes roles are confused, pretending that grades or a qualification of resident performance is enough as feedback. An appropriate feedback should be descriptive, ideally written and narrative, more than a rubric or a checklist. It must be given face-to-face and listening resident opinion about his own performance. Feedback seeking and giving are skills that need to be trained and practiced before using it in an assessment activity. We already know that without feedback, shy residents don't develop their potentials, and overconfident residents tend to become errant professionals. Clinical skills are underestimated and theoretical knowledge is overestimated in grades and promotion. An effective feedback is immediate specific information about the observed performance, compared with previously known standard and blueprinted. The last topic of this presentation is to give some highlights about how to build a structured program of assessment. What we understand as a structured program of assessment? Basically, is the arrangement of a longitudinal set of assessment tools to optimize the learning process, and is more than a random set of good instruments. Just imagine we put in a timeline a set of stakes from the start to the end. Every stake is an assessment event that gives us specific learning information. Aggregated stakes will be useful to pass, fail, or remediation decisions. The decision about how much formative or summative an assessment stake is depends on the moment it is set in the career. Initial assessment stakes will be predominantly formative, and final assessment stake more summative. As Robert Stake said, when the cook tastes the soup, that's formative, and when the guests taste the soup, that's summative. Other characteristics of assessment stakes that must be considered and will be discussed in other conferences are standardization, Miller's pyramid level assessed, and number of assessors. Initial stakes will be more formative, standardized, focus on first level of Miller's pyramid like multiple choice question exams. Final stakes will be more summative, less standardized, focused on the last Miller's level and result or aggregate of multiple assessors, like oral exams, logs, or clinical evaluation exercises. In this slide, we summarize characteristics of assessment stakes. In summary, we conclude that competence assessment requires multiple tools and multiple assessors. Assessment is a longitudinal cyclic process from low-level to high-level stakes. Assessment program stakes must consider formative and summative, standardized and non-standardized, quantitative and qualitative, and effective feedback and trained assessors are essential. Thank you very much for your attention.